Tired of the conflicting advice in the world of health and wellness? Ready for clear, science-backed strategies to live a longer, healthier life? Welcome to the Duration Wellness Show. We focus on health and wellness education to help you become a better, more informed you. Wherever you are on your journey, we're here with you for the duration.
All right, well, welcome to the Duration Wellness Show. I am Dr. Anna Marie, today's host, certified internal medicine doctor, board certified, and also with a master's of public health and a love of preventative medicine. And today I have Dr. Rama, who is a board certified cardiologist who also helps run a weight loss clinic, but it's kind of more complex than that. So excited to have you here. And, we're going to talk all about weight loss and some weight loss medications, but I thought first we'd just kind of touch a little bit about your background as a cardiologist and why you decided to start a clinic that helps with weight loss too.
Yeah, thanks so much, Anne-Marie. I'm so excited to be here to talk to you this afternoon because I have a passion in treating obesity. So I am a board certified general cardiologist. I like prevention. And around 10 years ago, I started, noticing that most of my patients have obesity as their primary problem. So they may have coronary artery disease, they may have hypertension, they may have diabetes, but really the 70% of the patients that we see in our cardiology practice have obesity. And so I started, going to lectures about obesity and we figured out that there's really a big effect if we deal with our obese patients a different way. And so that's how I got started with it. So here at Baptist Heart, we started the Cardiometabolic clinic. So it's not just seeing patients who are being consulted for patients who have obesity, but we really deal with complex patients. So patients who have obesity, diabetes, they have all the risk factors, CKD, liver problems, and of course, coronary artery disease.
Yeah. So from a heart health perspective, why is weight loss so important?
Oh, it is so important because we know that, first of all, that obesity has been associated with so many other diseases, right? So coronary artery disease is one of them because it causes a lot of inflammation. And I think that because of that, you end up with coronary artery disease. Hypertension, that's the first thing that you see when you treat obesity. Dyslipidemia is affected by that. So a lot of these things are kind of intertwined. And so, it's time to look at the patient as a whole and not treating them as silos. So a lot of times when we have complex cardiac patients who have all of these metabolic risk factors, the endocrinologist takes care of the diabetes part and the obesity part. The internal medicine takes care of one other part, and then we get to take care of coronary artery disease. So I think we're trying to shift now, looking at these patients as a whole and targeting all of these risk factors just to give them better outcomes.
Yeah, no, I love that.
Yeah.
What do you think is one of the most common misconceptions about weight loss?
Well, if it's not just 10 years ago, people were considering patients who have obesity as just, not having willpower, right? Yeah. So they always say, oh, you know what? You just tell them to stop eating and they should lose the weight. Yeah. But that's really not the case. So we know a lot about obesity now and the pathophysiology of obesity. It's not just a matter of people not having willpower. A very important study that I think a lot of people who study obesity should know about is Sumitran's article that came out in the New England Journal of Medicine in 2011. And it really highlighted that obesity is not just because you want to eat all the time and you don't have willpower. So they found that they basically took 50 patients, they put them on a strict diet. So you're talking about 500 kilocalories a day. And these patients lost a remarkable amount of weight, like 30 pounds, which is very good for just lifestyle, right? Yeah. And so they followed these patients and they took hormones levels. So they took the hormone levels of the ghrelin, which is the hormone that makes you feel hungry all the time. And they took the hormone levels of, the hormones that make you feel full, right? Yeah. So like leptin and CCK and all that. And what they found out that after 8 weeks of intensive diet, they told the patients, okay, you can eat whatever you want. Let's just follow you through the year. So they stopped the intervention after 8 weeks. And what they found out was all of these patients started regaining their weight back.
Wow.
And when they measured the levels of the hormones, the ghrelin hormones, so the metabolic adaptation. So what actually happens is that your body thinks, okay, I need to get you back to your original weight. Yeah. And so all of this metabolic adaptation, it's sustained for years. So there's still, the ghrelin levels were still elevated, and the hormones that make you feel full, those levels were down for at least 1 year. So it really points to the fact that people who have obesity, this is a constant battle for them. This is not something that's fixed with a 3-month diet, or let's go on a keto diet and lose the weight, because they will eventually gain it back because of this metabolic adaptation. So I think that's thinking now that it really is a disease has changed, our approach to obesity as a whole.
Yeah, no, that makes sense. I mean, I think people are understanding it's so much more complex. The whole
Absolutely.
just eat less and move more is not really a exactly true concept. And not like for people that really struggle with obesity. It's wild how all those hormones have such a huge effect.
Absolutely, yeah.
So when would you say that somebody who is, has been trying to lose weight, when should they, stop trying to do it all on their own and actually talk to a doctor?
Yeah. So a lot of times, so the indication for really treating obesity is if you have a BMI, even just overweight patients, right? If you have a BMI 27 and you have risk factors like hypertension, obstructive sleep apnea, that, you should be, seeing a doctor and talking to them about obesity. I think as a medical profession, we should really look at the BMI as the fourth vital sign, right? We deal with their hypertension, we deal with their heart rate, and we ignore BMI basically. And so I think that every step of the way, once you see patients starting to gain weight, you need to be talking to them about healthy diet. Not everyone needs to go on medications, but if you want to, interrupt this and start them with this healthy lifestyle, I think starting it early on is the best way to go about it.
Yeah. And who do you think would do best for like a medically supervised weight loss program, or like who would be, a good candidate for like your clinic?
Yeah, so for our clinic, ours is a little bit unique because we, take care of patients with underlying coronary artery disease. So a lot of our patients have had strokes, heart attacks, they have congestive heart failure, obstructive sleep apnea. So we kind of address obesity as a whole. So when we see our patients who have obesity and have all of these other risk factors, we do try to address the weight at that point.
Yeah, that makes sense. Are there, you kind of touched on it a little bit, but are there certain conditions where you say, for this person, it is especially important that you would lose weight?
Absolutely, yeah. So patients who've had prior heart attacks, if you have peripheral artery disease or prior strokes, people with congestive heart failure, particularly the HFpEF population. So those are the population of patients with heart failure because their heart is very stiff and just doesn't relax well. So people with obstructive sleep apnea, diabetes, patients with CKD, those are the patients that we deal with in our practice.
Yeah. And it is wild, like all the things that it's, like you said, the body's so complex and it's all, related to each other. And so all of these diseases that we see, a lot of inflammation is such a driving factor. And so, with the weight gain, all that inflammation goes up. And so I think a lot of people probably don't realize how much it is linked to and how much it can help, with some of these diseases.
Yeah, absolutely. Yeah.
Before taking medications, what lifestyle changes would you say matter the most?
So the diet is actually the thing that causes you to lose the most weight, right? Yeah. It is easier to reduce your energy intake by 500 kilocalories a day rather than burn 500 kilocalories a day. So diet is really the mainstay for losing weight. And, there are people who can do different kinds of diets. So there are people who do very well on a low carb diet and a high protein diet, but there are people who don't tolerate a low carb diet. So it really needs to be tailored to our patients. What we normally recommend is, you have at least 70 grams of protein a day. Okay. And eating the protein before eating the carbohydrates. So that your satiety is, reached earlier on and you have the, healthier food in you rather than, your concentrated sweets or processed sweets. And so we do tell that we tailor the diet depending on our patients. Being cardiologists, the diet that we recommend the most because it has the most data is obviously the Mediterranean diet, right? It incorporates the grains, the healthy vegetables. Yep. People don't realize this, but the Mediterranean diet did allow meat. They were allowed their patients to have maybe 1 or 4 helpings of meat a month. Yeah. And so, and the most important thing is incorporating the fats, right? Yeah. The healthy fats like avocado, olive oil, and nuts. And so as cardiologists, that's the one that we really adhere to. If you can be plant-based, I think there's a lot of data there that plant-based is probably better than having, not being plant-based. However, Mediterranean diet, if you stick to the principles of that, I think that's a good diet to start with.
Yeah, I know there's so much data on that. And even now, in terms of dementia prevention, which makes sense because a lot of the same factors, that cause cardiovascular risks also increase like your risk for dementia. But there's so much there. So I guess that touches a little bit on the nutrition aspect. Is there anything else that you wish people understood more about, like calories and protein and like just food quality for weight loss?
Right. Yes. So you want to stick with the high quality foods, right? The food that gives you the most energy. Sticking with around 1 to 1.5 grams of protein per kilogram. So that's what we recommend. So anywhere between 70 grams of protein to 110 grams of protein. So your plate needs to look like, one half of the plate has your healthy vegetables. You don't want the starchy vegetables. And then you have some protein, 1/4 of the plate. And then the other 1/4 of the plate is your healthy fats. So keeping that, there's so many diets out there, right? Yeah. So essentially getting away with the sweetened, drinks, getting away with the concentrated sugars. Those are the things that we would recommend somebody does.
Yeah, I know. Yeah. People don't realize, all the sweet teas and sodas, they add up quick.
Yeah.
How important would you say exercise is for weight loss versus just for overall health?
It is very important for overall health rather. It contributes around 20% of weight loss. But the thing with exercise, it helps you maintain the weight loss.
Yeah.
Okay. So we want that to be a combination. So we recommend 150 minutes of exercise a week, but we recommend that you do some cardio and do strength training, particularly with our patients who are on GLP-1s, because you do lose some 30% of muscle mass and around 70% of fat mass. You really want to maintain that muscle mass. Yeah. And so, strength training is very important in this case as well. So we recommend they exercise 150 minutes a week. We exercise the heart healthy diet. We also emphasize sleep. So sleep is also very important.
Yeah, which kind of leads me into the next question is how much does sleep actually affect weight loss? Like in terms of like appetite, cravings, people's metabolism?
Oh, it's very important. So you know that when people have the graveyard shift, the first thing that happens to them is what? Is they start gaining weight, right? Because sleep is so important. It regulates everything. So if you want 7 to 8 hours of sleep, if you have less than that, it actually increases your risk of obesity, diabetes, and more, and weight gain. So it all affects that. And so what we know now is that the lack of sleep increases your ghrelin. So remember, your ghrelin is the bad hormone, makes you feel hungry all the time. And when you're awake at that time, you tend to eat more. So it increases your ghrelin and it increases your calorie intake by 300 to 500 kilocalories just by working at night and staying awake.
I believe it though, because I remember in residency those overnight shifts. I mean, those are always when I would like grab the junk food, grab the chips, it's like, I just think your body is, you're tired, your willpower is not there. And then you have all of these other background things like your ghrelin increasing. And so,
absolutely. And when you're stressed out, the reward center of your brain is telling you, give me something that makes me happy. What is that? That's usually carbohydrates. And so, you have really bad choices at night when you're not sleeping well.
Yeah. And then how would you say stress makes it harder in terms of weight loss?
Stress is also a very important thing. You've heard about people who are stress eating, right? You have increased cortisol levels when you have a lot of stress. And so what it does is you're constantly in that fright mode. And when you're in the fright mode, you want to conserve energy. And so what happens is you have a lot of visceral fat. So which is not the healthy fat. This is the inflamed fat that people tend to store when they're under a lot of stress. Yeah. And of course, stress also leads to poor sleeping habits. And so it's a vicious cycle. Then you have people who become obese because they're not sleeping well and they're eating more of the bad calories at night. Yeah. You remember too that, the body is used to the circadian rhythm. So the body knows that at night you should be sleeping and you shouldn't be eating. And so it doesn't really know how to process all of these carbohydrates that you're eating late in the night. So, telling our patients you need to eat at least 7 to 8 hours. You need to have at least 7 to 8 hours of sleep a day is very important. Yeah.
Yeah, I think that's important. So I think the next topic would kind of be, weight loss medications.
Sure.
They're all the rage. I feel like everybody now has heard of Ozempic and Wegovy, but I think maybe starting with like the main categories of medications that people should know about.
Yeah. So of course there are oral medications that we're not using as much right now. So I guess you were looking at the GLP-1s, right? Mm-hmm. So there are only two GLP-1 formulations that are really approved. One is the GLP-1 agonist, which is semaglutide. Mm-hmm. And then the other one is a GLP-1 GIP combination. So it has two incretin hormones, and that's your tirzepatide. So those are the two major categories of the injectables that we're using nowadays. Everything else is not FDA approved. Okay. So if you're getting something else besides these two medications, you're probably getting it compounded, which has a lot of different issues that we can talk about later on.
Yeah.
So so those are the main categories of the newer injectables that we're using now, and really very good results when when patients start taking these medications.
Yeah. So I think, now, because I feel like commercial that comes on, there's at least one for these new medicines. So I feel like people have heard of them.
Yes.
I think a lot of people don't understand how they work. So How would you say, I know it's complex, there's like multiple, but like the main ways that it works.
Right. So when you eat, what happens is that your once the food touches your intestine, particularly the lower intestine, the L cells of your intestine releases a GLP-1. So the GLP-1 gets released, and the GLP-1 has a lot of beneficial effect. But the main effect of the GLP-1 is to send a signal to your brain and say, hey, you got to stop eating. Otherwise, you're going to be eating all day, right?
Yeah.
However, that naturally occurring GLP-1 stays in your bloodstream only for 1 minute. So 1 to 2 minutes, because it's degraded by DPP-4. So it's degraded right away.
Yeah.
And so what these companies have done is they figured out a way to extend the half-life of the GLP-1, because we know that it signals satiety. It tells your brain, okay, you got to stop eating, and it has other different effects, right? And so now the companies replace around 3 proteins in that GLP-1 molecule. And what it has done is extended the half-life of the medication to 1 week instead of just 1 to 2 minutes. And that's why it's very effective. So the effect of signaling your brain, telling you to stop eating, lasts that whole week instead of just for a few minutes.
Yeah, that makes sense.
Yeah.
For people who are on these, what sort of weight loss do they usually see?
There's the difference between that and the tirzepatide. Obviously, this tirzepatide has two incretin hormones, right? It has the GLP-1 and the GIP. Mm-hmm. So with the semaglutide, you would expect a mean of around 15% of weight loss. With the tirzepatide, which has two components to it, which is the GLP-1 agonist and the GIP, there's a little bit more robust weight loss, around 20% of weight loss.
Okay. Is it very common that you would start with just the GLP-1, and then if somebody kind of hits...
No, nowadays, because the FDA has approved one over the other for certain conditions, we base it on what the comorbidity is.
Okay.
So for example, so semaglutide, which goes by Wegovy, has been approved to reduce MACE. So MACE means your major adverse cardiovascular events, right? For patients who've had heart attacks, who've had strokes, and peripheral artery disease. Okay. And so when we have a patient who has this conditions, we would tend to give them the Wegovy. The Wegovy, also semaglutide, has been approved for MASH, or your metabolic dysfunction associated liver disease, which a lot of people know as fatty disease. Because it has the indication for that, that would be our first go-to medication. Okay. Now, if you have an obese patient, or a patient with obesity who has sleep apnea, because tirzepatide has been approved for sleep apnea, we would go with tirzepatide in those patients. So we look at the indications. And so also for HFpEF, there's some data, although tirzepatide has not been approved for HFpEF or congestive heart failure, we would go with tirzepatide for those types of patients. So we look at the type of patients and determine which medication would go well for them.
That makes sense. Mm-hmm. It's exciting that it's getting approved for so much more.
Oh, absolutely. Yeah. And there's a lot more in the pipeline. I mean, I think this is a good time to be board certified in obesity medicine, because you're talking about maybe five more, some are even more powerful in causing weight loss. And the indications, they're looking at Alzheimer's, they're looking at so many different things. So I think that it's a good time. It's a good time for treating these patients. And it's about time. Patients have been suffering with having obesity for such a long time that it's about time that we have treatment for them.
Yeah. And would you say that these medicines are more for just overweight people or obese people? Like, is it that if you are obese, we kind of talked about it, this is very helpful with these, especially with these health issues, but for people who are overweight and not actually in the obese category, but they have health issues, are they also helpful for them?
Yeah. So the indications for anti-obesity medications right now is if you have a BMI of 27, so that's not the obese category. So 27 with at least one risk factor, which is hypertension, dyslipidemia, obstructive sleep apnea, obviously diabetes. If you have that, then you will qualify for these medications. Now, if you're in the obese category, if you have a BMI of 30, you don't have to have any comorbidities to qualify for these medications.
Wow. How often, I'm just curious, how often now that that's like qualifying, how often are insurance companies actually paying for it? Or is that still lagging?
So that has been an issue because if you think about the cost of these medications, they cost around $1,300 a month. So that is the cost of the medications. Now, what we found out is that the insurance, it's not so much the insurance as it is the employer. So if you're in your benefit plan, obesity medications are covered, it can go down. So for insured people, it can go down to as low as $25 a month. So, or even zero. So, for example, Baptist Health covers anti-obesity medications. So it would cost $0 to $25 for patients with that. If you don't have any coverage, then you're stuck with the $1,300 a month. However, this, we recognize that, these medications are life-saving for a lot of people, right? And so there's ways to pay for it as self-pay now. So like Novo Nordisk that produces or manufactures semaglutide, they have the NovoCare, which drops the cost of the injectable to around $199 for the first dose, and then like $349 to $399 for the higher doses. And then it's the same thing for tirzepatide, which is Zepbound. You could get, if you do self-pay and go directly to the company, it still needs a prescription of a doctor. You can get the first dose at, I think it's 150, and then it goes up to around 450 max for the maximum doses. So it's not cheap by any means, but still better than having to pay $1,300 for the medications.
Oh, absolutely. I know. And I think so. I didn't actually look this up to verify it, but I think I saw something that Costco even was going to have like a discounted program where if it was prescribed by, a physician and everything, that it was, I want to say like it was under $300. It was
right. So also, we have to remember too, Wegovy just recently came out with a tablet. So the tablet is an oral tablet that you have to take every day. It's, so it has the same indications as the injectable Wegovy, and those are cheaper. So the starting dose of that is like $150, and then it goes up to $399 for the higher doses. And so, so they're doing a lot of things. Now, Medicare is different, right? So Medicare, I've been surprised because Medicare will pay for these medications if you have the comorbidity. So we're just talking about Medicare with Part D. So if you have, if you're the SELECT patient, so SELECT was the trial that showed CV outcome improvements. So if you had a heart attack, if you've had a stroke, or if you have peripheral artery disease, they will approve you to have Wegovy. And it goes into the Part D. So the Part D means that you pay $2,500 as your deductible, and after that, the medication is free for the rest of the year.
Wow.
So it goes with the Zepbound. So the Zepbound, if you have obstructive sleep apnea and you can prove that you have moderate to severe obstructive sleep apnea, Medicare will pay for the medication as a part.
Awesome.
Right. But there's something exciting going on with Medicare. I think the government had basically partnered with the manufacturers. So come July 1st of this year, the Medicare Bridge GLP-1 is going to start. And this is for Medicare patients. And for my understanding, it doesn't matter if you're Medicare, plain Medicare, or if you're Medicare Advantage. But for these patients, all the GLP-1s and the GLP-1 GIPs are going to cost $50 a month.
That's awesome.
For 6 months, right?
Wow.
So what they're trying to do is they're going to do this, get this patient started on this medication for $6 a month, $50 a month.
Yeah.
January, what they're hoping is that the insurance companies will continue this. Now, so that is iffy. So we don't know if the insurance company is going to start it off, but I think the cost is going to be even lower at that point. So we'll see what happens. But it's definitely good news for people who have Medicare.
Well, and it makes sense too, because if you think about it, people on Medicare are probably going to stay on Medicare, and these just decrease so many other medical issues.
Oh, yeah.
So like cost-wise, it would actually make sense for, Medicare to cover it, because now you're going to decrease all the comorbidities that
Oh, absolutely.
So
I mean, you can't imagine how many patients have had to stop their blood pressure medications on. So the first thing that we see when they have even just 5%, 10% of the weight loss is their blood pressure starts going down.
Yeah.
So I have patients wherein the only medication they're taking is the GLP-1. They're off their blood pressure medications, they're off their diabetes medications, and the only thing they're taking is the GLP-1.
Yeah, which I think is so huge. And I think a lot of people don't realize that, that it can have that sort of effect. I think that kind of, is the next question is, what's the biggest benefits, apart from the number on the scale? And I mean, those are real benefits. That's like huge.
Yeah, it is. The mortality. So when they did the SELECT trial, it's very interesting. When they did the SELECT trial on Wegovy, so they basically enrolled 17,000 patients. So this is a very robust trial, 17,000 patients during COVID, but people stuck to the medication because they were losing weight, right? Yeah. So almost an average of 3-year follow-up. The reduction in mortality and strokes and recurrent MIs was 20%. And this was on patients who were already on aspirin, statins, antiplatelet medications. So this were on top of standard of care. Yeah. We haven't seen this in a long time.
No, that's huge.
Yeah, it is. Because and the effect too was really beyond they saw the effect or beneficial effect within 3 months before any significant weight loss has occurred. So this patient haven't, So the effect was within, if you look at the graph of the people who were taking the GLP-1s and the ones who were taking placebo, it splits up in 3 months, and people weren't really losing that much weight in 3 months. Yeah. And so there is another effect of the medication. We still don't know what it is. So one of the things that we have to remember is, you remember the Jupiter trial that looked at rosuvastatin in patients who were high risk but never had cardiac events? Yeah. They had a 40% reduction in cardiac events, right? And it was beyond also the lipids. The lipids went down a little bit, but the important thing is the C-reactive protein dropped by 34%. Right. So the SELECT trial did show that Wegovy dropped, the C-reactive protein in these patients. You know how much? 34%. Same as a statin. Yeah. Wow. And it's in the trial. If you look at the trial, it's right there. It says that. So it's not just the weight loss. I think the inflammation has a lot to do with it as well. Yeah. No. And I think that's in so many disease processes that we're realizing is that inflammation is such a driving factor of that. Absolutely. All the chronic diseases that we think about, even cancers, it's all inflammation, right? Yeah.
No, absolutely. So I would say, from a cardiology perspective, we kind of just touched on it, but what would you say this helps specifically for heart health? It seems like it helps so much with the heart.
It is, yeah. And as I told you, the first thing that we see is, we see a reduction in their blood pressure medications. Yeah. They feel better. The most important thing, though, is they start moving. Yeah. Because when you lose all the weight and it's so surprising, because you know what, I'm starting to exercise. Overall, I just feel so good. They're walking now. And so that just promotes a lot of the weight loss, right? So it's not just the calories that are going down. It's really, exercising, moving more. And so I think that's one of the biggest benefits of the medications. And so we take them off their blood pressure medications. We take them off their blood sugar medications. The diabetes is remarkable as well. So these medications are marketed as diabetic medications as well, as you know, and you can see them, we take away their sulfonylurea ureas, which I hate anyway because they have no cardiac benefit. If not, they're really bad for the heart. And so we stop those medications. The insulin requirements go down. So I think that in the long run, I think there's going to be a cost benefit overall for these medications, especially when the cost of the medications goes down over time. And I think it's going to be just a matter of time.
Yeah. And then, like you said, I mean, because there's the mortality benefit, but then there's also just the whole comorbidity effect. So it's like, not only are you like decreasing, if you're able to stop this, at an earlier process so that people aren't getting all the heart attacks, that they're not getting all the strokes, that they're not getting all these, it's like then you're going to have happier, more active, healthier people who can like enjoy
Absolutely,
life. That's huge. That's
exactly. Yes, absolutely. Yeah.
So I guess we have to get into risks because, and side effects, because that's, every medication has, something that's, a side effect too. So what would you say are the most common side effects that you see?
The GI by far is the most common side effect. So the most common reason for people to stop the medications is GI. So you're talking about nausea, vomiting, diarrhea, or constipation, abdomen, so those are the most common. And that happens probably in 5% of the patients.
That's little. I actually expected it to be way more than that.
No, it's around, when you look at the studies, it's anywhere from 5, maybe 10%, but it's not that much. Okay. So I tell my patients nausea and vomiting is something that you would expect. Some people don't feel it, right? But there are some people who are going to have that problems. It usually is while you're titrating the medication. So the most complaints are during, and the reason why we start the titration. So if you have a doctor that gives you the highest dose possible, that's wrong. You have to go to another doctor. Yeah. To mitigate the side effects or the GI side effects, you really need to start slow. So everyone starts at the lowest dose possible. Yeah. A lot of times, you feel the nausea. Most patients feel it like a wave of nausea. It's usually between the first 2 days after the injection. And then as time goes by, you're not going to feel the nausea anymore. And then as you titrate it higher, you have less of the side effects as well. Now, we have patients who can't really tolerate it. So we tell these patients, if you really can't tolerate it, you have to watch out, because if you're not eating, you have to make sure that you're able to drink water. If not, we've seen renal failure in patients, not because of the direct effect of the medication on the kidney, but because of dehydration. And so, you have to be careful with these patients. That's why we watch them closely, maybe get them back in the office in 1 to 2 months, especially if they're having the side effects, and making sure they're well dehydrated. Now, I tell my patients, okay, nausea, vomiting is common, but abdominal pain isn't common. So if you do have abdominal pain, you have to watch out for gallstones and pancreatitis. Yeah. You remember in med school that regardless of how you lose weight, if you're losing weight, the gallstones is really affected, and there's an increased risk of cholelithiasis in these patients. And so tell them, if you have abdominal pain and pancreatitis, which really occurs only in 0.2% of patients, so it's not even a common thing, right? Okay. But if you start having the classic thing to stop the medication and to make sure that they talk to us about it, then we may have to run some tests just to make sure they're not having any of those 2 complications or 2 side effects.
Yeah. Are there any other really serious side effects that?
So those are the major ones. So when they looked at the SELECT trial, they actually enrolled patients over the age of 70. So there were some people who were over 70, over 60, and over 80. They had a slight increase in hip fractures. So hip fractures, yes. And I think part of it is because of the loss of muscle mass, but we really don't know. So there's a slight increase of that. Children who have, the children who are on, because it's Wegovy now is approved for children who have obesity, right? Yeah. If they're 95 percentile of their weight, they can have it. They had a slightly higher incidence of cholelithiasis compared to their adult counterparts. So something to think about. Yeah. Now, the MCT, so that there are 2 contraindications to the medication. So one contraindication is if you have a history of medullary thyroid carcinoma. Right. And the other one is if you've had anaphylaxis with any of the ingredients. So those are the only 2 contraindications or black box warning for that. Okay. The MCT is a very interesting thing, though. Okay, so the MCT, or the medullary thyroid carcinoma, is one of those generic, really weird thyroid cancers, right? So we're not like talking about papillary thyroid carcinoma. This is, and there are very deadly carcinomas, right? And then it comes with the M2, or the endocrine tumors as well, right? So sometimes it's familiar. So if you have a patient who had a history of that, or a family history of that, you don't want to do that. And the reason why is because the rat thyroid glands apparently have a lot of C cells in them. So in the GLP-1s attach to the C cells, so to their thyroid glands. And so when you overstimulate it with GLP-1 agonists, there's an overstimulation of the C cells, which causes the medullary thyroid carcinoma. The interesting thing is that in humans and in primates, you don't have that much C cells. So the effect on humans is very different.
Okay.
And so even if it's still in the black box warning, but I've been doing this for years. I mean, semaglutide has been around, the GLP-1 agonists have been around for 20 years.
Yeah.
See very little of that MCT.
Yeah.
But right now it is in the black box warning.
Okay.
Yeah.
And then I feel like there's a lot of people talking about all the muscle loss with this.
Yes.
Is that a real concern? How do you help patients prevent it?
Yes. Well, you have to remember, any type of weight loss, when you lose weight loss, you're going to lose muscle mass and you're going to lose fat mass. Muscle mass is around 30%. Fat mass is around 70%. So still losing more fat than that. So we tell our patients the strength training, crucial. So you have to be doing your squats. If you're walking, you want to make sure you walk with weights, or the weighted vests and things like that. So that's very important. And I think it's also important for older individuals, right?
Yeah.
Because they're the ones who have tendencies to fall, and that the fracture rate in individuals are a little bit higher.
Yeah.
So it's important to incorporate that, and incorporating protein in their diet as well. I think is important in protecting them from that.
I know. I was reading something and they were advocating for a lot of the patients who are on this, and obviously then this is an increased cost.
Yes.
For people to get like a bone density scan, to kind
Yes.
of monitor like their muscle and how much muscle they're losing, and to kind of help in terms of like titration, which I thought was like a good thought, because it's, measurable, but.
Yeah. And we have the Sika scan too, that looks at your fat mass versus your muscle mass. So one of the things that, if they exercise, you tell them, hey, you're having a lot, you're the comparison of your fat mass to your muscle mass, you're having a lot of the fat mass. And so when you start exercising, you see that change. And sometimes people like that. It's just not readily available for everyone. So, yeah.
Yeah. When people start these, and we talked a little bit about like the GI effects, is there anything that they can do to try to decrease like the side effects from the medication? Like if somebody's going to start this?
Yeah. So remember, it causes early satiety. Mm-hmm. So you have to eat slowly. Because the problem is, if you eat too fast, then you don't know that until you're really, really sick, that you're overeating. So we tell our patients, make sure that you eat small meals rather than big meals. Make sure that you eat slowly, so that it has time for the signals for your brain to tell you that, hey, you're full already, stop eating. Yeah. There's a thing that I joke I always talk to my grandchildren, my children about, and it's called hara hachibu. Have you ever heard of that term?
No.
It's a Japanese term. It's hara hachibu, and it says, the Japanese has a way of saying that eat until you're 80% full. Which is very different from the American way of thinking, right? So when we were growing up, what did they tell you? You finish your food. You
got to be a part of the clean plate club.
Exactly, right. But when the Japanese are hara hachibu, you're 80% full, you stop. So that's what I tell my grandkids to do now. But those are the things. And avoiding fat. People get really sick when they have a fatty meal on GLP-1s. Interesting too is alcohol. So a lot of people really don't want to drink alcohol when they're on GLP-1. It's like, it's like all of those reward centers, just they don't feel it. So avoiding alcohol when you're on GLP-1s is also one of the things that we advise patients.
Yeah, no, I think it's cool. It's obviously off-label, but they are finding that it helps with addiction. So like even, different like issues with addiction, alcohol addiction, but also like, other drugs and things like that. I think it's so cool.
Yeah, and drinking a lot of water. So we tell our patients, drink lots of water as well.
Yeah. How closely should people be monitored when they're on these medications? Because I think, people can sign up online. There's Hims and Hers. There's like all these sites now where you could just go and get it prescribed. Like, what would you say for the average person? Like, if they're going to do this, like how closely should they be?
Yeah, so we follow our patients during especially the titration period. So we see them in our office every 2 months or every 3 months. That's the follow-up that we usually do. So we get them in here for weigh-in and titration of the dose. In 2 to 3 months.
Okay.
Yeah, they should be followed. No, so one of the important things too is that you have to think about the medications, right? So the medications don't interact. So the GLP-1s don't really interact with any medications. But so for example, somebody who's hypothyroid. So you remember that levothyroxine is weight-based.
Yeah.
Right. So once they start losing weight, there's actually been an article in JAMA that saw because of a patient who started GLP-1, lost a lot of weight, but the thyroid hormone or the TSH level was not followed and ended up with hyperthyroidism. So things like that you have to think about, adjusting their medications for high blood pressure. So that's one of the biggest things, like within 2 months, because some people lose an incredible amount of weight, even just starting it. They can lose 10 to 20 pounds, which is unheard of before, right? And so the first thing that they complain about is like, I feel so dizzy when I stand up. Yeah. And it's just a matter of adjusting their antihypertensive medications. And that's why we get them early, because a lot of our patients have these comorbidities. Yeah.
So I think, next section would kind of be more like common questions people would ask. I feel like a lot of people, say, hey, these medicines are a shortcut. But I think, as we've talked about, I think they're more of a legitimate medical tool. What would you say to the person?
Right.
Hey, these are just
like once we treat diabetes with insulin, we don't stop the insulin. So I think people need to start thinking of obesity as a chronic illness. So it's not something like once we get your blood pressure controlled, we don't stop your blood pressure medications. So it's the same concept. As a matter of fact, there was a study, the step 4 study that looked at patients on Wegovy, and one group of the patients stopped the Wegovy and was given placebo, and the other group was continued on Wegovy. The people on the Wegovy arm basically lost another 17% of their weight, and the people on the placebo arm started gaining their weight, around 7% of their weight gain. So one thing that's very important is if you stop the medication, you will probably start gaining the medication. But if it's having all of this beneficial effect, right? If it's preventing you from having a second heart attack or a second stroke or cardiovascular death, why would you stop the medication? So when they start looking at the medications for the cardiovascular benefit or the obstructive sleep apnea benefit, they're more likely to stay on the medications. And I really, because a lot of patients still come to me saying, I want it for 6 months. That's not the way it is.
Okay.
If you can't commit to the medications long term, then you shouldn't start the medication.
Okay. Well, I think that's something good for people to know, that it is more long term. Do you find that they have to stay on the same dose long term, or are you able to kind of go down on the dose?
Sure. Yeah. So there are some patients. So, it's funny because when you look at Wegovy, which is semaglutide, since the studies looked at the benefit at 1.7 and 2.4 milligrams, which is the top dose, some of the insurance companies will not allow you to maintain people on the lower dose. So they'll stop paying for the medication unless you get them to the maximum dose.
Really?
So it's different for tirzepatide. So tirzepatide, do you have the titration dose, which is like 2.5, and then 5 is the maintenance dose. If they don't lose weight, then you go up to 7.5, and then 10 is their maintenance dose. So, with tirzepatide, you just titrate them to the dose that gives them the maximum benefit, right? So if they've reached their goal at 5 milligrams, then we stop at 5 milligrams. For Wegovy, what we've done with the patients is that, we titrate them up to 1.7 or 2.4. And it's not, this is not what's in the package insert, but in some patients, if they're losing too much weight, I might tell them to, instead of doing it every 7 days, to do it every 10 days. Again, not in the package insert, but some patients, it works well for them. It should save them money as well. Yeah. So, and so, sometimes I have patients on tirzepatide 15, and then all of a sudden I'm seeing that they're losing too much weight. I might drop the dose to 12.5, but keeping them on the medications.
Okay, that makes sense.
Yeah.
Would you say that somebody can take these medications and still have poor habits, or I mean, I'm sure that they work best when they're paired with lifestyle changes, but what do you usually recommend for your patients?
Yeah. So again, we let them know that so in our practice, Baptist has a health coach that
That's
we
awesome.
can. Yeah. So when I start the patients and medications, I send them to a health coach so that we're it's the lifestyle. It's a cornerstone for treating. It's not like, although patients just want to take the medication and forget about the lifestyle, the lifestyle is an important part. And, as physicians, unfortunately, we don't really have time to tell patients about, what are you supposed to eat? What are you eating right now? And you need somebody like that. Yeah. And so Wegovy has a program wherein once you prescribe Wegovy, you can go to the We Go Together program where they're assigned a one-to-one coach.
That's awesome.
Exactly. And so they look at your what are you eating now? They kind of do that. And that's a very good program. And, because these medications are popping up, I mean, so many patients are on these medications, and we realize the need for the lifestyle portion of it. There are a lot of online programs that's coming up. One of them is Nourish. So Nourish is a dietitian that you can really talk to regardless of where you are in the country. And it's an online program, and it teaches you the lifestyle part of it.
That's awesome.
Yes, it's very important. Yeah.
What would you say to somebody who kind of feels ashamed or judged that they're even considering a weight loss medication?
Yeah, the good thing about it is that because the results are so good, that's kind of out of the, it's not.
Stigma is less now.
Yeah. Before it was like, oh my gosh, they're ashamed of it. But now they come to you and they say, can you help me with this? Yeah. And when you bring it up to patients who don't bring it up, that they're not, they don't want to address it, and you tell them the health benefits of it, that it's beyond the weight loss, it's beyond fitting into a size 4 dress. Yeah. It's because you want to live longer, you don't want to get diabetes, you want your blood pressure controlled. They're more likely to accept it as a medication. I think a lot of times we've looked at weight loss medications that we should take this so that we can fit into a dress and go to prom or whatever, right? If you shift away from that and tell them, no, we're doing this because it reduces your inflammation, it reduces your risk for all of these chronic illnesses. If you look at diabetes, it's been associated with 260 diseases, right? Yeah. Including 13 cancers.
Yeah.
What the effect of the cancers is, we don't know. Yeah. But if the inflammation goes down, it can only be good, right? And so when you talk to them about that, they're more likely to accept it as a medication really to make you more healthy, because it really affects a lot of your risk factors for these chronic illnesses, rather than just a weight loss medication so that I can lose weight and look good.
I think so many people don't realize, in terms of for cancer risks, that obesity and diabetes, that they all increase your cancer risk for
absolutely
so many cancers. And so
I
think that's
there's 13 cancers that it's been associated with, and the prevalence of all cancers have gone down except for those 13 cancers. Yep. And it's because the obesity rate has been going up. So what's if you are you're a public health specialist, right? Yeah. It would be interesting to look at, because when they were looking at the obesity rates in all of the states, right, the 51 states here in the state, here in the United States, the obesity prevalence has been going up. I mean, this is the fattest our country has been in all of these years. It would be interesting to look at it 5 years from now, when a lot of these medications are really being used, on did we stop that epidemic? And I think that there's going to be a significant reduction in the obesity rates in the States.
Yeah, I think so too. I mean, they really, I know, have made a huge difference for so many people. And I think that has then helped people, like you said, take away that stigma of asking for the medications, and people are actually talking about it. It's not like something I feel like before people were nervous to bring it up, or they wouldn't.
Absolutely.
So
and I have patients who who, it's very interesting. The first patient that I treated with this, we told them, it actually cried and said, my BMI has been going up every year, and all my doctor told me is you have to stop eating. And that's all they said, and it's weird. And then now that they have it, they're just tearful, and they're so happy to have this available for them.
Yeah.
Yeah.
So I think, we talked a little bit about the cost, but one thing I wanted to bring up was compounding, because, a lot of people hear about like the compounded versions. What should people know about the compounded version?
Of it. Yeah. Better not to. So I know that. So the compounding came about because there was a shortage of the medication. So when the FDA said, okay, there's a shortage of semaglutide and tirzepatide, it allowed compounded companies to compound the medication to fill that gap, right?
Yeah.
But as of February of last year, they have been taken off the shortage list. So there's a lot of these medications available at this point. I understand cost is still an issue. The compounded medications are still cheaper, but they have looked at the compounded medications and they've actually found out that it has a lot of impurities. I mean, including formaldehyde, and because they're not regulated by the FDA, their manufacturing the manufacturing method is not really looked into. So they found more impurities in the compounded formulations. The other thing is that you're more likely, because what happens with the compounded one is they give you a vial and you keep reusing the vial, right? So drawing the perfect amount. Have you seen the instructions for that? If you're not a nurse, so the overdose rates and the underdosing rates for compounded has been tremendous as well. Yeah. And so we stay away from compounded. Interesting too, if you're a physician that prescribes it, look at your medical malpractice insurance, because some of the medical malpractice in Baptist, the medical malpractice doesn't cover any claims that involves compounded medications.
Wow.
So if you had pancreatitis and it was because of the branded Wegovy, your insurance will cover that. But if you have pancreatitis because of unbranded or compounded medication, they're not going to cover you. Yeah. So if you are a doctor, look at your medical insurance and look at your fine print, because if you get sued by somebody who got compounded medications, you don't have a legs to stand on, because your insurance is not going to back you up.
Yeah, which I have a feeling probably a lot of people don't know, because I mean, a lot of people won't read the fine print in like their malpractice insurance, It's
right.
That's wild.
Yes, it is wild, yeah.
So if somebody can't really afford their medications, like what other options are there, that could still help?
Yeah, sometimes you can talk. So the pill formulation is a lot cheaper compared to the IV or the subcutaneous formulation. So talk to your physicians about that. The Wegovy benefit actually, so the Wegovy tablet has the same indications as the injectable Wegovy.
Okay.
So reduction of MACE for patients with heart attacks. So they got the same indication because there's the same medications. Yeah. Now Eli Lilly came out with an oral, but it's not oral tirzepatide. It's still oral GLP-1.
Okay.
And so I don't know what the price point of that is going to be. It was just recently approved. Okay. It has probably an 11% weight loss. So it's not as good as Wegovy or tirzepatide, although there hasn't been a head-to-head comparison. Okay. But that would be a good start if the price point is okay. And then again, the Medicare Bridge GLP-1 program will help a lot of our patients.
I know. I think that's awesome. I didn't know about that.
Yeah.
Have you noticed any differences with like the oral Wegovy versus the injectable in terms of like patient benefit or side effects or anything like that?
Yeah. So far it's been good. So we just started our few, because it just was approved like a couple of months ago. So they're just coming in, and some of them they first of all, these are patients also who don't like injections, right? Yeah. It's kind of strict in the way you take the pill. So you want to take it first thing in the morning on an empty stomach with no more than 4 ounces of water. And you can't have coffee, you can't have anything. Really? Because the way the pill is the way the pill is made, it's not absorbed if you have food or other things in there. So it's 30 minutes before breakfast, and people comply with it. And so far, the people that we've put on it have had significant weight loss, almost the same as the injectables.
Okay, that's awesome.
Very good. Yeah.
I wonder, did they do, you might not know this, did they do the same studies in terms of like CRP and the inflammatory markers on?
Right. So they didn't have to, because semaglutide was considered the same compound. Okay. It's Wegovy. Yeah. So they got the indication for it based on the SELECT trial.
Okay. Yeah, I was just curious.
The same medication, it's just given a different way. Yeah.
Yeah. In your clinic, like who do you see that tends to do really well with this medication versus they struggle with it?
Okay. So believe it or not, the people who have a lot of weight to lose are the ones that respond to it well. So the percentage of weight loss in patients who start with, 300 pounds, 250 pounds, they can lose up to, I think the most that I have is 140 pounds. It's
Wow.
incredible. It's incredible.
That's awesome. Yeah.
So if you don't have a lot to lose, and you have to remember too, like 5 to 10% of the patients are going to be non-responders, unfortunately, that they don't lose that 5% of the weight, and we can't continue the medications in those patients. So there are going to be non-responders. There are, and then as far as the side effects are, you got to try the medications to know if you're just going to be one of them that's not going to tolerate it.
Yeah. For the non-responders, do you ever see if you switch, like let's say you started them on Wegovy and then you switch to, a different, does it make a difference or not really?
Yeah, sometimes it does. Yeah, sometimes it does. Switching from Wegovy to Wegovy tablet probably won't make that much of a difference. Yeah. Switching from semaglutide to tirzepatide and vice versa, sometimes we see a difference.
Okay, that's cool.
Yeah.
What would you say are some early wins patients notice beside the weight loss?
Oh, blood pressure. That's the first thing. Blood pressure. And then, that depression with anti-obesity medications, regardless of how you lose the weight, you always have to think about, depression in these patients. But so far, I've had 2 patients who had depression that I had to stop the medication. And it's a weird kind of depression. It's like they don't know why they're so depressed. It's like, I don't know what happened. I just feel, and there's just 2 patients that I had to stop it. But a lot of the patients have such a positive outlook after they start the medications because they can move, they have less pain. They sleep better. The joint pain goes away. And so these people just are happy. And so I think once they see, and a lot of patients who we start these medications on have been on tons of diets. So a lot of them yo-yo. They've been to Weight Watchers, they've been to Noom, back to Weight Watchers, gain the weight, back to weight, so it's a lot of that. And so once they see a sustained weight loss, it's just so good for them. And so so getting that first 10 pounds out they're the happiest. Yeah. But for us, we're happy because we get them off blood pressure medication. So we see it early on too.
Yeah, that's awesome. What would you say is like a safe and sustainable weight loss amount?
So we have to. So the most that patients, we always say 1 pound a week is what we want. But frankly, with this type of medications, we've had really significant weight loss. Mm-hmm. So 2 pounds, 3 pounds a week, especially starting off, is what we see. Yeah. That tends to taper down along the way. Okay. So, when you're kind of, it slows down like anything else, right? Yeah. So the first 3 to 6 months, they have very, very strong or robust weight loss, and then it kind of slows down. And then, because the body's not going to make you dwindle away. It's going to stop at some point. Yeah. And that's going to be your set point. And so, you see that it slows down later on. Okay. But what we've seen is as much as 5 pounds a week of weight loss, which is a little much, but you know what? You just tell them you just drink lots of water, continue exercising, and they overall do very well on the medication if they don't have the side effects.
Yeah, that's awesome. Yeah. How do you help patients kind of set realistic goals?
So because when we look at patients, our patients are kind of different. So they're not coming to us just for weight loss. It's really for the cardiac events. Yeah. So we tell them, I always let them know that there are people who are not going to be responders because I don't want them to be disappointed. So It's not, it's just one of those things. Some people don't respond to it. They realize all of the benefits when they start having to adjust their medications and getting off the medications. Yeah. And so, it's different for different people. It's always going to be a bell-shaped curve where some people don't respond. Some people are going to be really good responders, and you have the middle, which have moderate response to the medications.
Yeah.
So, yeah.
For someone who's kind of overwhelmed, what would you say is the first step?
So some people, believe it or not, are not ready to start the medications because a lot of times they hear things from, social media. They this is you're next every week. There's one thing that this medications cost. It looks like, right? To just scare people out of taking the medication. But, so so for those patients who are not ready to take the leap and go into this the GLP-1s, we start with diet and exercise. Let's see how you do. I give you 3 months, okay? This is the diet that you have to do. This is the exercise you have to do. Come back in 3 months and let's see and then a lot of times at that point, they're ready to do it.
Yeah. Well, and I think the other thing that I also tell patients is that these medications have actually been around for a while. But I think just now people are hearing of them because of all the weight loss and people using them for weight loss. And so I think that also helps reassure patients like, oh, wait, this hasn't just been around for like the last few years. We have some long-term data on this, So
absolutely, because they don't realize that it's this, similar to Saxenda. So I tell them, we have had these medications for 20 years, so we have data on it. And that kind of, they feel better when they're knowing that.
What questions should a patient ask their doctor before starting a weight loss medication?
So the things to ask is, realistically, you need to know what the side effects of the medications. You need to know if you're somebody who can qualify for it. I mean, I have patients who come to me with a BMI of 25, and you just have to tell them, no, you really don't need this medication, right? But because they're saying, well, there's so many cardiac benefits. I said, it's cardiac benefits in patients who have obesity, not in patients who are thin to begin with. So, so whether you qualify for it and then giving them, finding out from the physicians, do you think that my insurance will pay for it? Because that's a big deal for a lot of our patients. A lot of patients cannot pay for $450 a month for this medication. So getting that out of the way and say, do you think my insurance will cover it? And then asking them, what do you think? Is it a benefit for me? Do I have the underlying risk factors? Do you think that losing weight because of my hypertension is going to be good for me? So those are the things that you ask the questions that you ask, especially the side effects. What side effects should I expect? So in my patients, constipation is one of the big things with my patients. I always tell them, magnesium helps well in the patients. You'd be amazed. It's an over-the-counter medication. You just take one a night and it really regularizes your bowel movements. So, things like that, side effects, if it's indicated in their case and what's the cost going to be.
Yeah, that makes sense. I feel like the other side effect somebody told me, and it's, I guess, common, is that people have issues sleeping. Do you hear that one a lot?
I haven't heard, mostly because of the GI side effects, you mean? So some people, because of the delay in the gastric emptying time, there's tendencies for the food to stay really in your chest, right? And some people, it's worse than others. So they're not able to sleep because of that. Just the medication, not being able to sleep with the medication, I haven't heard that as a main complaint. One weird side effect that people don't know about is what we call formication. And what it is you have this bug-like feeling in your skin, like it's crawling.
I've never heard of that one.
It's like heroin or something. I don't know the mechanism of action, but I have one patient who's like, I don't know what to do. It's like, feels like things are crawling on me. So, with those patients, we give them some Claritin or Benadryl to go to bed. And a lot of times it does go away over time. But if somebody tells you that I have this thing, like it's crawling in my skin, it's probably your GLP-1s.
That's so interesting. I hadn't heard of that one. That's definitely different. I heard some people get like their heart rate increases just a little bit.
And so then there's a reason for that, right? So there are GLP-1 receptors in the sinus node, actually. So when you stimulate the GLP-1 receptors in the sinus node of your heart, it causes tachycardia. And the increase is around 3 to 4 beats is basically the mean or the average increase in heart rate. However, there are patients that it can go up to 20 beats a minute. And so we mitigate that by telling them to drink more water, to avoid stimulants like caffeine. They shouldn't be drinking sodas anyway if they're trying to lose weight. But so that's a true thing. And you have to reassure them that it's not atrial fibrillation because because it's the effect is on the sinus node, not atrial fibrillation. So it's not atrial fibrillation. As a matter of fact, what's going to be interesting is that a lot of my EP colleagues are sending me there are patients who are overweight or obese, who have overweight or obesity, because the studies have shown that in atrial fibrillation, if you lose your weight, it reduces your risk of having recurrent atrial fibrillation by 50%.
Really?
So that would be interesting to see. That's the first thing that patients with atrial fibrillation, the thing we tell them is if you lose weight, you're probably going to have less AFib.
Yeah.
So it'd be interesting
awesome
to see what the effect is on AFib, but we don't have studies looking at that yet.
Yeah, but I mean, it makes sense in terms of like if it's treating sleep apnea, right, and decreasing the incidence of that.
Oh,
like all
absolutely,
yeah. I mean, it does make sense. So, but that's cool.
Yeah.
So, if there were two things that the listener had to take away from today's conversation, what would you say those would be?
Yeah, so if you've been battling with obesity all this time, it's really not, there are neurohormonal reasons why that is. Your body is trying to get you back to your old weight. And so don't think of that as a failure or you just being lazy. So, and the good thing too is that there are medications that's out there that just doesn't make you lose weight, but also it really reduces your risk for serious complications of obesity. So, be open to it. But the cornerstone of all this is still lifestyle. So you can't just take the medication. You have to really adjust your lifestyle as well.
Yeah.
And the medication helps you to, it's easier to adhere to the lifestyle changes when you start losing weight. So hopefully a lot of these patients are walking more and eating more healthy.
Yeah, I think that's like one of the most encouraging takeaways from this too, is like, right, it helps people start losing weight. And then when they start losing weight, like they want to go for the walks, their knees don't hurt as much. They feel a lot better, so I think that's like a huge positive. So
that is true. Yeah.
Well, this was awesome. I know I learned a lot in here too, which was great.
Yeah.
I think these, a lot of people have heard of these medications, but don't fully understand everything about them. So this was great. So I definitely appreciate you taking the time to talk with us about this.
Of course, anytime.
This was great. Thanks so much.
Thank you so much.
Thank you for joining us for the Duration Wellness Show. We hope you feel equipped to apply today's science-backed insights to your daily life. To find show notes, past episodes, and all the resources we mentioned, visit us at durationwellness.com. As always, this podcast is for informational and educational purposes only and does not constitute medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed by guests are their own and do not necessarily reflect those of the host. We'll see you next time, and as always, we're here with you for the duration.